to today's case study carrying on our CNS theme. Today's video revolves around anti-epileptic drugs, or AEDs, and epilepsy. So let's start. The question reads, one of your regular patients, 33-year-old Mrs. AED, enters into the pharmacy. She complains her seizure control hasn't been good the last few weeks, and so tells you her consultant decided to add on another anti-epileptic drug to help get her seizures under control. Mrs. AED tells you she also went to see her GP today. She tells you she went to ask for a weight loss drug, Orlistat, she read about on the internet. She heard it works wonders and wants to shed those last few pounds to get her BMI from 27 to 25. Whilst there, however, she forgot to ask whether taking the new hormonal contraceptive she started last month with food will make any difference in terms of its effect, since she finds it easier to fit with her schedule. She hands you the following prescription. Identify the 2 drug therapy problems present. Now, in neuronal cells, which are found in the brain, messages are normally sent via electrical and chemical signals. Now, normally patients with epilepsy have this hyper-excitable neuronal activity in the brain. Now, that can be in one area of the brain, also known as a foci, or it can be in all areas of the brain, or it can spread from that foci to the rest of the brain. Now, reducing this excitability, therefore, can hopefully help, prevent a patient from having a seizure. So we can do this through different means, such as terminating the electrical activity, sometimes referred to as an action potential. So terminating those action potentials. Another way, so we can do that through changing different concentrations of positive ions by either reducing the amount of positive ions or increasing the amount of negative, or we can increase the amount of inhibitory neurotransmitters. One of our primary inhibitory neurotransmitters, such as GABA, can help prevent a high amount of electrical activity, or we can decrease the number of excitatory neurotransmitters, one of the primary ones being glutamate, and so on. And so there's different means we can do this. And how AEDs work is they look at ways to reduce that hyper-excitable electrical activity in the brain using different messages such as those discussed just now. So if we come back to our prescription, the first drug therapy problem is actually to do with what's called a pharmacokinetic interaction. Now, lamotrigine, which is our AED, is actually principally metabolized in the liver. Now, its metabolic process, about 80 to 90% of it, is via a process called glucuronidation. Now, estrogen, such as that found in combined oral contraceptives, such as microgynon, which is being taken by Mrs. AED, has been found to induce this glucuronidation process. And obviously, as our lamotrigine is metabolized via this pathway, that means that we're going to have a reduced amount of lamotrigine circling in the blood because this glucuronidation process has been sped up. Now, this probably explains why Mrs. AED's seizures have worsened recently. So this interaction, it should be flagged up with the prescriber because it's quite important. Different options may be discussed, including giving the patient potentially a progesterone only pill as a form of contraceptive, as it doesn't contain any estrogen. Other options may include trying non-hormonal methods of contraception, so that may include the partner wearing a condom, or these are just different things that might be discussed. Now, our second drug therapy problem, coming back to the prescription, is again a pharmacokinetic interaction, but this time between Orlistat and our lamotrigine, which is our AED, anti-epileptic drug. Now, this interaction aside, she doesn't even fit the minimum BMI criteria of 28 to use Orlistat. So if you look, Mrs. AED wants to go from 27 to 25, so we know her BMI is 27. And normally for orlistat, the minimum criteria, normally they have to fit a few other criteria as well, is 28 anyway. So she didn't even fall onto that. Now back to our interaction. There have been documentation of patients' seizure control worsening when starting on orlistat. This is most likely due to orlistat reducing the absorption of many AEDs. So it decreases the absorption. Now, a few mechanisms have been proposed for this. Many put consensus to this due to orlistat's mechanism of action or mode of action. Now, orlistat basically acts to inhibit gastrointestinal lipases. Like lipases are they're enzymes that help involved in digestion of fat. And so, you know, they reduce dietary fat absorption to help the patient to lose weight. Now, take note that many AEDs also tend to be, you know, fat soluble. Why do they have to be fat soluble? Well, in order for, you know, these antiepileptic drugs to pass through the blood-brain barrier, they have to be fat soluble in order to pass through. So if they're not fat soluble, they may not pass through. That's why the majority of antiepileptic drugs tend to be fat soluble. So already you can see our problem here. So by inhibiting lipases, it's going to reduce the absorption of anything that's, you know, contains fat, and that includes reducing the absorption of our AEDs. And so the patient might not hit that threshold to control their seizures. And so that's important to flag up with the prescriber. So, you know, different options can be sought. Lifestyle changes is something that's important that the patient can try. Normally, always a dietary and exercise plan should be put in place that's appropriate for that patient. Obviously, we can see the patient seems to think orlistat will be, quote, the solution, but it should only be used as an adjunct, and the patient may not have tried these things, and she isn't even suitable in this case anyway. Bringing up with this up with the prescribing clinician may be one option that's tried, and different things will be discussed. Now, with both drug therapy problems identified, let us move on to the patient query portion. So our question reads, Mrs. AED comes in complaining she can't sleep properly because her husband snores and snorts all the time throughout the night and takes up quite a bit of room on the bed because he is so overweight, even though that is less of an issue. Mrs. AED says she is getting really irritated now as well about how he seems to be the one complaining he feels all the time when he gets 10 hours of sleep every day. Mrs. AED asks if she can purchase Sominex, promethazine, since she saw an advert on the TV that it helps with sleep. Now, it's important to note a drug like promethazine may actually lower the patient's seizure threshold. So if a patient's seizure threshold is lowered, they're more prone to getting a seizure, and so it may worsen the patient's seizure control. So that's one thing that you normally see with sedating antihistamines like promethazine. So that's probably going to be a one thing that we have to think about. Also, the root problem will not be identified. You will just be plugging the symptoms, but actually just giving her a sedating antihistamine to help her sleep. So what could be causing the issue? Now, you should be thinking, why is the husband snoring? Especially with the symptoms that he has. For instance, does he have obstructive sleep apnea? Now, many patients that are obese will often complain of fatigue during the day, and they may snore, and that's often picked up by someone else, and it's a sleeping disorder that patients may not even know about. As I said, it's normally the spouse or someone else that picks up on the snoring. Now, what exactly happens in sleep apnea? So imagine a patient's, lying down, and this is your tongue, and this is your uvula. That's that little flap. If you look in someone's mouth, you can see that little flap tissue hanging down in the back of the throat. That's the uvula. Now, what happens with sleep apnea? Usually the throat muscles, they intermittently relax and block the airway. So you can see they normally intermittently relax and block the airway, and that basically acts to interrupt our normal breathing. Thus the term apnea, and that literally means without breath. This also produces the characteristic snoring that Mrs. AED is hearing, and sometimes even they can have a potentially reduced oxygen consumption, which is why the patient may feel fatigued during the day. And sometimes these patients may even wake up, gasping, or sometimes they'll just snort throughout the night, like Mrs. AED is hearing. Now, this should be flagged up and the patient, told to refer her husband to see the GP. Now, sometimes an oral occlusion device may be prescribed, and this is a device that fits around the teeth, and it holds the jaw and tongue forward to increase that space at the back of the throat so more air can get through. And sometimes the patient may be prescribed a continuous positive airway pressure device. Sometimes you'll see the acronym CPAP written. Now, this continuous compressed air basically prevents the airway closing, and it's normally given with a mask. Now, lifestyle changes as well can be tried, such as losing weight. Patients that are obviously obese, as I said, tend to have tend to have this issue, and losing weight has seen to have a dramatic positive effect. In the meantime, other non-drug therapies can be tried, such as the patient or their spouse can sleep in different rooms, or if it is sleep apnea, the husband can try sleeping on his side. Be careful of patient confidentiality when speaking to, obviously, the wife. Now, that wraps up today's case study. If you found today's video helpful, please give it a thumbs up, and don't forget to subscribe to the channel, making sure you hit the bell icon, of course, to keep updated on new videos.